again.
We'll try to leave.
Hey Abby, how's it going? You busy? I want to join a case with you real quick. Sure. It is. Well, is it sarcoidosis is the reason.
Oh, wait, you're not on mute.
Thanks.
I don't know about this.
Mine is 2276.
All right. Good afternoon, everybody.
Yep. So she's a 59-year-old.
Good afternoon, everybody. My name's Eric Snowden. I'm doing a presentation on Parapneumonic effusions in Empyema. I have no disclosures. Here's the outline of the talk today. I'm going to talk a little bit about the historical perspectives, definitions, epidemiology, some anatomy and physiology, pathogenesis, the clinical presentation, microbiology, diagnosis, management, complications, prognosis, and then some take-home points after. So here's a little bit of pictures of a historical perspective of Empyema. Hippocrates right here was the first and is most famously credited with first describing Empyema in 500 BC, but it actually was the Egyptian physician Imhotep who first described Empyema in 3000 BC. Hippocrates is famously quoted saying, persons who become affected with Empyema after pleurisy, if they get clear of it in 40 days from the breaking of it, escape the disease. But if not, it passes into the phthisis, and phthisis means systemic circulation. So he described it in 500 BC. Until the 19th century, open thoracic drainage was the recommended treatment for this disorder, but carried an associated mortality of 70%. Closed tube drainage was first described in 1876, but was not widely adopted until this happened. And can anybody guess what this is? Around 1916, 1918? Influenza epidemic. And that's when Dr. Everett Graham formed an Empyema commission. And he produced recommendations that remain the basis for treatment today. They advocated adequate pus drainage for a closed chest tube, avoidance of early open drainage, obliteration of the pleural space, and proper nutritional support. These changes reduced mortality to 4.3% during the later stages of this epidemic. So this was a pretty big advancement at that time. And this is a little bit more modern day. In 1923, Dr. Eagers at Walter Reed Hospital treated 99 patients with Empyema with decortication, with over 2/3 of them healing well. Dr. Tillett used streptokinase and streptodornase for intrapleural debridement, Parapneumonic Empyema in 1950. I don't have a picture of Dr. Glennert, but in 1950, he found that pleural fluid glucose was an indicator for chest tube drainage. And this is a very famous Dr. Light right here. Suggested that low pleural pH was an indicator of tube drainage, and he also came up with the Light's criteria. And this is a picture of the VATS procedure, which has become widespread in the treatment of loculated pleural effusions over the last 1 to 2 decades. So here are some definitions. Pleural effusions develop when the balance of pleural fluid formation and removal is altered. And a parapneumonic effusion is any pleural effusion associated with bacterial pneumonia, lung abscess, or bronchiectasis. A simple, uncomplicated effusion is sterile and free-flowing exudative effusion. A complicated effusion is an effusion associated with infection. It's often loculated and typically requires pleural drainage or surgery. And an empyema is a bacterial infection of the pleural space, which results in pleural fluid or positive granulate. Why is this important? It's because 1 million patients hospitalized each year in the US with pneumonia. Of those hospitalized, 20 to 40% have a parapneumonic effusion. I thought that was a relatively high number considering how many people we treat with pneumonia. Mortality is higher in patients with pneumonia who have a pleural effusion. There was one study that showed the mortality risk was 6.5 times higher if the effusions were bilateral, whereas the mortality risk was 3.7 times higher if the effusion was unilateral. Complicated parapneumonic effusion occur in 10 to 15% of these patients. An empyema, which is pus in the pleural space, in 5% of these patients with a 15 to 20% mortality. Again, pleural infection occurs mostly in the pediatric and elderly populations, and large cohort studies agree with this finding. So here are some risk factors. A lot of them mirror the risk factors for pneumonia. Some independent considerations for developing empyema include diabetes, immunosuppression, steroid use, GERD, alcohol use, IV drug abuse. History of aspiration and poor oral hygiene is often elicited in anaerobic infections. And then we have the iatrogenic causes following pleural interventions and or thoracic esophageal surgery, trauma, or esophageal perf account for the majority of the remaining cases. However, many patients have no apparent risk factors. And here's a nice little table that shows some of the underlying etiologic conditions for pleural space infections. And I kind of mentioned all those already. So just to go over briefly some anatomy, it has the pleural surface has about a surface area of 2,000 centimeters squared in an adult male. The pleural space is 10 to 20 micrometers and contains 8 to 10 milliliters of fluid. The two layers are joined at the pulmonary ligament. The parietal pleural blood supply is from the intercostal arteries, and the visceral pleura is supplied by the bronchial circulation. The parietal pleura is the one that feels sensitive to pain, temperature, and touch and pressure, and it's innervated by the intercostal and phrenic nerves in different areas. And the visceral pleura is supplied by the sympathetic nervous system from the pulmonary plexus. The lymphatic drainage, the parietal pleura drains into the intercostal, mediastinal, and diaphragmatic lymph nodes, and the visceral pleura into the bronchopulmonary lymph nodes in the hilum of the lung. This is a nice little schematic that was in New England Journal of Medicine pleural disease review article that shows basically what the hydrostatic and oncotic pressures in the pleural spaces, and showing that the amount of fluid in the pleural space is dependent on the balance of hydrostatic and oncotic pressures between the parietal and visceral pleura. Because the hydrostatic pressures are higher on the parietal pleura than on the visceral pleura, and the oncotic pressures are equivalent, pleural fluid is primarily produced from the parietal pleura. Likewise, the lymphatic vessels in the parietal pleura are responsible for the majority of the pleural fluid reabsorption. So the normal pleural fluid is an ultrafiltrate of the pulmonary circulation. It gets into the pulmonary interstitium and squeezes in between the visceral pleura to enter the pleural space. The parietal pleura has these stomas that are very small, 2 to 6 microns, that expand and contract when breathing. They swallow that pleural fluid and filter it into the lymphatic circulation. So I always think when I do a thoracentesis on somebody, it looks like beer when you tap the fluid. And I said this to Dr. Peralta the other day, and he said that I ruined beer for him. So I'm credited with that. The picture, number one, I always think is looks like a Bud Light. It's minimal foam, transparent. It's usually transidative. Number two is like a Blue Moon or a wheat beer. It has foam. It's somewhat murky, but still light. It's either a long-standing transidative versus an exudative fluid. And then you have your amber ale here, almost always exudative, Parapneumonic effusion versus malignancy. And then you have your Guinness or Imperial Stout, and it's likely exudative, long-standing versus malignancies. So we normally create 0.1 to 0.2 milliliters per kilogram of clear pleural fluid. It's low in protein. Most of it's albumin. You usually have less than 1,500 nucleated cells with 61 to 71% monocytes and macrophages, 9 to 30% mesothelial cells, 7 to 11% lymphocytes, 2% neutrophils, and no eosinophils. It's alkalotic with a pH of 7.60, and the LDH is usually less than 50% of plasma LDH. Compared with the serum, the pleural fluid contains greater levels of bicarb, lower levels of sodium, and very similar levels of glucose. The rate of production is 0.01 cc's per kilogram per hour, and the rate of absorption is 0.28 cc's per kilogram per hour. And again, the pleural fluid absorption is a function of the parietal pleura. And the pleural fluid formation has to increase by over 30-fold to create an effusion. I thought that was an impressive number. So this is a very important slide. It kind of discusses the pathogenesis of parapneumonic effusions and empyemas and the evolution of them. There's 3 different stages. Stage 1 is the exudative stage. This begins as a sterile exudative effusions. Neutrophils and monocytes cross the pleural mesothelial layer and enter the pleural space. The presence of these neutrophils and monocytes induces intrapleural increase in inflammatory cytokines, IL-6, IL-8, and TNF-alpha. And these inflammatory cytokines increase the vascular permeability, causing sterile pleural effusions. And then you have your second stage, which is the fibropurulent stage. And this is an infection of an exudative effusion that leads to a transitional fibropurulent phase, increased vascular permeability, and permits microbial migration into the pleural space. This is where you have the combined metabolic activity of infecting organisms and host phagocytes that lead to reduced glucose and pH levels and increased lactic acid and carbon dioxide levels in the pleural fluid. Loculations usually develop during this stage. Purulence develops during this stage, yielding empyema. And then you have your third and final stage, which is the organizing stage. This is fibroblast proliferation, which initiates chronic or organizing phase fibrin to produce deposits into the pleural space. This is intrapleural membranes thicken and become inelastic. And this produces what's called a pleural peel, which may prevent lung re-expansion. You don't want to get to this point. So here's the microbiology. Before antibiotics, the bacteriologic species were predominantly gram-positive species, pneumococcus and beta hemolytic strep. With the wider use of antibiotics, the bacteriology has changed. You can kind of divide them into community versus hospital-acquired bacteria. As you can see in the community, Streptococcus species are around 52%. And MRSA and Enterobacter are more prevalent in the nosocomial empyemas. And anaerobic bacteria are cultured in greater than 20% of pleural space infections and may be due to the common association with aspiration of the anaerobic environment of the pleural space. Polymicrobial infections are very common, and empiric antibiotic regimens before obtaining culture results should include coverage for anaerobes. There's also fungal and TB, and then certain endemic areas that if you have a patient with a travel history, you might need to elicit that. So clinical presentations, symptoms usually mimic that of pneumonia. They usually have a fever and cough. They'll have dull pleuritic chest pain, shortness of breath, sputum production. They can either be acute or chronic. I think that it was interesting. I read that anaerobic pulmonary infections frequently have been are characterized by a more chronic course. They'll have weight loss and anemia that are common with anaerobic infections. 60% of patients in one study showed significant weight loss with a mean of 29 pounds. In patients with pneumonia, the clinical picture, such as degree of leukocytosis or the incidence of chest pain, is very similar, and whether or not they have a parapneumonic effusion. So here are some imaging studies that can help define our parapneumonic effusions. Here's a chest X-ray of a patient I took care of actually last year, and you can see the blunting of the costophrenic angle on chest X-ray. Usually you can see this when the fluid is more than 400 or 500 mLs. The presence of pleural fluid is easiestly picked up on a lateral decubitus chest X-ray. As you can see, there's a vertical lens shape here. There's associated pulmonary infiltrates that may present a fixed opacification of the pleural space. And then we have ultrasound, which is more sensitive than X-ray for small pleural effusions, and you'll have the presence of hyperechogenicity and septae, which may suggest an empyema or complex effusion, as you can see in this. Another good thing about ultrasound is it helps determine the volume and location of the fluid collection, and more precisely, and maybe used to guide thoracentesis. And here's a CT image. CT, you want to give it with IV contrast because it helps to visualize the pleura better, and it can help define the parenchymal abnormalities. This CT shows a loculated pleural effusion, which is parapneumonic in origin. The pneumonia, it's not shown here, is cuts above this level. We have thoracentesis. It's the hallmark of diagnosis for parapneumonic effusions and empyema. It starts with sampling the pleural fluid. I'm not going to speak on the technical aspects of this procedure. We all know how to do them. All patients should have diagnostic pleural fluid sampling if they have a pleural effusion and sepsis or a pneumonic illness. Pleural fluid pH assessment should be performed on all non-purulent effusions when pleural infection is suspected. If you can't do a fluid pH measurement, perform a pleural fluid glucose assessment. This is required to distinguish uncomplicated sterile from complicated infected infusions, and it changes management. You can also have both diagnostic and therapeutic removal of the fluid that can have symptomatic relief. The pleural fluid, like I showed you with the pictures of the beers, it can vary though. It's clear, it could have a yellow exudate, it can be thick, it can be foul smelling, it can have pus. If the odor of the pleural fluid is feculent, the patient is likely to have an anaerobic pleural infection. But only 60% of anaerobic empyemas have a foul odor. So pleural fluid analysis. So these patients should all get cell count with diff, total protein, glucose, pH, LDH, culture, and gram stain. Cytology, adenosine deaminase, fungal, and AFB if indicated. And you always get your total protein and LDH, should get blood cultures and a CBC in the serum. So what tests will confirm the diagnosis of empyema in this patient? Thank you. It's there. Yeah, the eye test. So that's an empyema. So frank pus. CRP question mark, procalcitonin question mark. These novel biomarkers of infection have been evaluated for possible utility in distinguishing empyema from uncomplicated pleural effusions, but they're far less useful than the traditional pleural chemistries. This is Light's criteria. We all know about it. It's not going away. I'm not going to read this out again, but you just have to have one of the following characteristics. Light's criteria has been around since 1972. And there's been numerous studies testing its sensitivity and specificity, positive predictive value, negative predictive value. And it stands its ground. It stands its test of time, and we still use it today. So pleural fluid analysis. Here are a couple of the things that suggest complicated parapneumonic effusion and need for further drainage. This is, if you have a patient that has this, you should be thinking this patient's pretty sick. The pleural fluid changes as a parapneumonic effusion moves to progressively higher stages. The fluid is culture negative. The bacteriology just becomes positive. As a parapneumonic effusion progresses, the pH and the glucose levels become progressively lower, whereas the pleural fluid LDH become progressively higher. And do you guys know what the most sensitive pleural fluid measurement is to indicate a parapneumonic effusion is complicated? Glucose? Glucose? Glucose is the second one. It's pH. pH falls before glucose drops. So if you have a pH of 7.5 to 7.2, that indicates usually complicated parapneumonic effusions. And then the leukocyte count, total protein level, you can get a CRP level, but frankly, purulent or turbid cloudy pleural fluid or a positive culture or gram stain, those are going to be your empyemas. So Light created his own classification of parapneumonic effusions and empyema. As you can see, it's a pretty cumbersome table. He actually acknowledged that it is cumbersome and it's an impractical way to approach parapneumonic effusions. Mostly they use this now to enroll patients into research, but from a practical and clinical standpoint, it's not really helpful. There's some other organizations, American College of Chest Physicians, the ACCP Classification, and the British Thoracic Society are two of the ones that I think are a little bit easier to follow. The ACCP classification has 4 stages: an uncomplicated parapneumonic, 1 and 2, and then stage 3 is the complicated parapneumonic, and stage 4 is empyema. And it basically goes over, the categories are amount of pleural effusion, the microbiology, the pleural fluid chemistry. And in the ACCP classification, they focus more on pH and glucose, and in particular, and it's not focused on LDH, as you'll see that the British Thoracic Society uses LDH instead of glucose, but it kind of gives you an idea of the management for these patients. As you can see, it tells you if they need a thoracentesis or they need drainage. And you can see that the big point is from 2 to 3 is when you need the drainage, and Empyema, you need definitive drainage as well. The British Thoracic Society classifications make it a little bit simpler. Basically doing fluid, simple parapneumonic effusion, complicated parapneumonic effusion, Empyema. And they do macroscopic appearance of the fluid, the microbiology, and the fluid studies. And again, the British Thoracic Society uses LDH as well. They did a study on which study was better, ACCP versus the British Thoracic Society. It's very similar. They all do how much amount of the pleural effusion, what the pleural space is looking like, what are the pleural fluid studies, and what is your microbiology. As you can see that the sensitivity is 97 and 98% and 60, and the specificity is 68 and 56%. So it's important to classify the prognosis when you see a patient with a parapneumonic effusion. The American College of Chest Physicians came out with this in 2000, and it's basically a classification on the basis of the anatomic characteristics of the fluid, A, the bacteriology of the pleural fluid, B, and the chemistry of the pleural fluid, C. And this is very similar to TMN staging that we use to classify tumors. It kind of just shows, based on imaging findings, 1/2 of the hemithorax occulated effusion, and is a big marker too. But it's just something that kind of guides your thinking towards how we manage these patients. Risk of poor outcomes, moderate, high, and when we require drainage. So management. It consists of appropriate antibiotic therapy and drainage. This is kind of a busy slide. It's showing our antibiotic choices on whether it's community acquired or hospital acquired. Community acquired is usually empiric therapy, typically directed at strep pneumo and anaerobes. And hospital acquired, we broaden the coverage to include MRSA and Pseudomonas. Your choice of antibiotics should be geared to the most likely organisms, and the antibiotics penetrance into the tissues. Some of the antibiotics that have good pleural penetration are the penicillins, the beta-lactams, cephalosporins, and Flagyl. Definitive antibiotic therapy should be based on culture and susceptibility results. One way to increase your culture and susceptibility results is when you're getting your fluid off your thoracentesis is to put it into a blood culture bottle. And that's something that we do here at Henry Ford. Optimal duration of therapy is not defined. About 3 weeks following drainage may be appropriate. You can transition to oral therapy when the clinical response is documented and effective oral agents are identified. There's been talk of some papers written that say serial C-reactive protein measurements may help assess response to therapy. So here's our different modalities for pleural fluid management. We have many ways to drain the pleural space. We have thoracentesis here. We have our Wayne pigtail catheter here. We have our different kinds of small bore chest tubes here, our large bore chest tubes. And we have a flexi-rigid pleuroscope, which is used under conscious sedation to break down adhesions and put a catheter in. I talked to Dr. Debian and Dr. Cohen, and they say that we really don't do that here, but it's something that could be thought of doing. Then we have that here, and then open thoracotomy. What's this? Yeah, it's not a shark bite. So this is an open window thoracostomy that it's actually healed up. The surgeon makes a big gash, makes a pleurocutaneous fistula, and they hook it to a colostomy bag to drain the fluid. So basically you don't, I mean, there's indications for this, but you want to do one of these before the patient needs to have this. So, well, the first thing we can talk about is the therapeutic thoracentesis. It was first practiced as a treatment modality in the early 19th century. And in 1962, the American Thoracic Society recommended repeated thoracentesis for non-TB empyemas that were in early exudative phase. Then in 1968, they recommended the patients with empyema be managed with 2 therapeutic thoracentesis. But if fluid accumulated after that time, then a tube thoracostomy should be performed. Therapeutic thoracentesis for parapneumonic effusion has been kind of an outdated treatment for the last couple of decades, just because you're not going to get good pleural fluid drainage and you have to constantly keep doing it. So there's different modalities for that. This is more of coming up with a diagnosis than treating our a complicated parapneumonic effusion or an empyema with repeated thoracentesis. So we have our chest tube drainage. So uncomplicated effusions typically resolve with antibiotics alone, and complicated effusions and empyema demand the pleural fluid drainage simultaneously with standard antimicrobial therapy. To date, the size of the chest tube remains an area of controversy with no established consensus. Large bore chest tubes have been traditionally used, especially if the presence of frank pus or frank pus in the pleural space, giving concern for obstruction. People always think that if there's frank pus in the space, it's going to block your chest tube, but that's not necessarily the case. So a small bore catheter, 10 to 14 French, has been proven to be typically adequate for drainage, but requires regular flushing, like 30 milliliters of saline every 6 hours to maintain the patency of the catheter. I think this, Dr. Debian made this sound like this was a consensus statement, and that's what they use. This similar protocol here at Henry Ford is that if you do have a small bore chest tube, you have to make sure that you're flushing at that 30 mils every 6 hours. It's key initial management. And then the removal of the chest tube when drainage is less than 50 cc's for 24 hours. This is also controversial, as some advocate for less than 150 cc's in 24 hours. So intrapleural tissue plasminogen activator and deoxyribonuclease, so your TPA and your DNase. So following initial cath tube thoracostomy, a residual collection of pleural fluid may continue to occupy the pleural space due to increasing degrees of pleural fluid organization and progression of loculated septations. If the pleural space is not drained with a small bore tube, the installation of TPA and DNase has been successful, and in the Mys2 trial was found to be associated with significantly better fluid drainage, a lower likelihood of being referred for surgery, and a shorter mean hospital stay. When performed twice daily for 3 days, intrapleural administration of the TPA DNase has been shown to decrease the radiographic pleural opacity, lower the rate of surgical intervention, and decrease hospital stay of patients with empyema. That is the Mys2 trial. But it should be noted that the TPA DNase has not been shown to decrease mortality. In addition, we'll speak upon this later, the VATS has also been shown to effectively manage empyema in greater than 90% of cases. And a delay in going to surgery increases the risk of an open thoracotomy. So this is the Mys2 trial, which shows that they're comparing the TPA with placebo, DNase with placebo, and TPA DNase, and then placebo alone. As you can see the change in baseline hemothorax area occupied by the effusion, which was the primary outcome that they were measuring, and the TPA DNase did significantly better than all of the other arms of the study. we have, they wanted to do a Cochrane analysis of the Mys2. This included the Mys2 and Mys2 trials, and it was 7 randomized controlled studies comparing fibrinolytic therapy with placebo. And it showed that fibrinolytic therapy was beneficial for the outcomes of treatment failure, surgical intervention, or death, and surgical intervention alone. And there was no difference in mean duration of hospital stay. So basically, mortality doesn't improve, you require surgery less, and you stay in the hospital less. This was a study that was a little bit later on that showed 10 trials of a total of 977 patients. They compared with placebo. Intrapleural fibrinolytic therapy decreased the odds ratio for surgical intervention and the length of hospital stay. It was also associated with a non-significant reduction in mortality and a non-significant increase in severe side effects. Subgroup analysis indicated that the urokinase agents had marked positive effects on reducing surgical intervention. So this is the main author of, this is Salidas. He's the main author of the Mys2 trial. This is kind of his expert opinion. It basically says that overall, the role of the fibrinolytic therapy and pleural effusions remains debatable in light of the Mys2 and Mys2 trials. And he quotes the meta-analysis as beneficial for improving surgical intervention or death in pleural infections. He basically says that it's his view that it's limited to patients with pleural infection who have already been treated with sufficient antibiotic therapy, where conventional pleural drainage has failed, and the patients are not suitable or unwilling to proceed to thoracic surgery, pending the results of larger randomized studies. So this is his expert opinion. Basically, it is helpful. It gets the patients outside of the hospital. Out of the hospital, it decreases the risk, but it should not replace your role of surgical therapy. This is a slide I just wanted to throw in there. It's called the PIT trial. It basically is a salvage therapy if TPA DNase has failed. This needs a bigger study. That you can see it was only 35 patients who instead received intrapleural saline irrigation with 250 ml bags of saline versus the standard of care, which we talked about earlier. I talked to Dr. Debian about this. He said that this would have to be a bigger trial to see if it actually works and is beneficial. They think that it works by a couple of mechanisms. It eliminates the modulation of the bacterial burden, as well as the associated cytokines, inflammatory mediators, and pro-fibrinogen coagulation factors. And it physically disrupts the organization of fibrinous strands and loculated collections by means of saline washout to accelerate the drainage. So there's going to be more on that coming.
How long did that dwell there?
They didn't say how long it dwelled in there. They didn't comment on that. So another thing that Dr. Debian said is that I mentioned earlier, the role of fluoroscopy. There's no randomized controlled trial to determine the exact role in pleural infections. It's more well-defined in malignant and TB effusions. And the current guidelines recommend proceeding to surgical intervention if medical therapy fails. So they did a retrospective study of 127 cases of multiloculated parapneumonic effusions treated with fluoroscopy, and it showed a success rate of 91% and only 6% conversion to surgical intervention. So I asked what this entails. So basically you take the flexorigid fluoroscope and under conscious sedation, you break down the adhesions and you put the catheter in. And we really don't do this here. It's not a standard of practice here, but it's something that can be considered in the future. So therapeutic failure. So if you have removal of the thoracotomy tube, should be warranted with resolution of sepsis, reduction in size of the pleural effusion, and lung re-expansion. However, if there is evidence of persistent sepsis, the patient must be assessed for adequate drainage, in addition to reevaluating whether the current antimicrobial therapy is sufficient. You should always check for malpositioning and dislodgement of the chest tube. Imaging with CT becomes imperative. I think that when at Henry Ford, they said, Dr. Cohen said that they follow up CT scans pretty frequently if they're not improving at a rapid rate, just to see if they need definitive therapy with surgery. And while intrapleural therapy may better facilitate drainage of the pleural space, you can always put in additional catheters and chest tubes to evacuate other walled off loculated pockets, particularly with complex effusions. If the underlying tube is occluded, expert opinion does recommend the use of large bore thoracostomy tubes, which is greater than 14 French. Again, early thoracic surgery consultation becomes prudent for consideration for surgery if the treatment that you're offering is not working. And the British Thoracic Society guidelines recommend getting them involved at the day 3 mark or day 3 to day 5 mark. So here are the surgical managements. This is in the form of VATS or open thoracotomy. It's reserved for patients who do not clinically improve with antibiotics, catheter tube thoracotomy, and a course of intrapleural tPNA DNase. The traditional indication for surgery was for the management of empyema. However, with the tPNA DNase therapy, there has not been a significant difference in mortality between surgical versus non-surgical management therapy. Again, there was a little bit of a shift with that intrapleural tPNA DNase and a different option other than surgery. But if your tPA DNase is not working, again, it's important to get surgery involved early for VATS decortication. So VATS, for surgical management of pleural sepsis in the setting of empyema, VATS remains the first line approach with success rate approaching 80%. It provides visualization and access to the entirety of the pleural space. It facilitates debridement and decortication of both the visceral and the parietal pleura. You use intermittent irrigation and aspiration. Loculated fluid collections are broken up and removed, and fibrin deposits are taken away from the pleural space with forceps and scrapers, among other tools to liberate the lungs. The advantages of VATS is you can visualize lung re-expansion immediately. And then overall, compared to open thoracotomy, VATS is far more cost effective with patients requiring less time in the hospital postoperatively, improved postoperative pain, and fewer complications from bleeding. There are some limitations for VATS. For one, the patient must be able to tolerate single lung ventilation. And the timing of surgery is important, as a higher conversion rate of VATS to open thoracotomy has been observed when performed much later from the onset of symptoms. So large bore chest tube versus VATS. It was one study that randomized 35 patients to VATS versus large bore chest tube. The success rate is VATS is 82% and large bore chest tube is 63%. And you can see that the length of stay in the hospital is shorter for VATS compared to the large bore chest tube. So you could ask, what if you put a large bore chest tube and put fibrinolytics in it? They did a randomized control trial for that, which was 20 patients at a single center. It was with a streptokinase, not with the DNase. And it's an older study. VATS did much better, less hospital days, less ICU days, and cost less. This was a study that was done in 96, I think, 97. Basically, the whole idea is if the patients are good surgical candidates with complicated pleural effusions, the best option is the VATS procedure. This is a 2020 trial. They took 32 patients with pleural infection were included in the study. The median length of stay after the intervention was 4 days in the intrapleural fibrinolytic therapy versus the early medical thoracoscopy. The total length of hospital stay was 6 days in the fibrinolytic arm and 3.5 days in the medical thoracoscopy arm. And there's no difference in treatment failure, mortality, or adverse events between the treatment groups, and no serious complications related to either intervention were reported. There is a multi-center trial with a larger sample size that is going to confirm these findings. So decortication, As you can see, this is decortication. You can note in this image up here that there's rib crowding, and in image B, there's a thick peel present with decortication being done. And C, you can see the lung has been completely decorticated and there's no residual dead space with complete lung re-expansion. Again, it involves the removal of all the fibrous tissue from the visceral and parietal pleura along with pus from the pleural space, and assist in expansion of the underlying lung. It also helps with source control for the pleural infection. And then open thoracotomy is what we saw earlier. This looks very painful. Sometimes it's unavoidable though. Chronic empyemas, especially with bronchopleural fistulas, usually is an indication for this. But then again, you want to avoid getting to this point by early therapy and following the classifications and the recommendations through the guidelines. This is the British, it's kind of hard to see. This is the British Thoracic Society management algorithm. The New England Journal of Medicine had a little bit clearer picture of it, kind of showing what to do in these patients. It's basically a good tool to have just to follow the algorithm. And you can see where fluid recurs, poor prognostic factors, where they recommend the 14 French chest tube, and then if they're good surgical candidates for VATS. So this is from New England Journal. And then I took this schematic from Up to Date. I think it's a good thing to have just as quick reference. It kind of takes the recommendations and classifications from ACCP and the British Thoracic Society and kind of puts them all together. And this just kind of shows the pleural fluid characteristics, the imaging characteristics, and what we do for treatment. And it's just, I think it's clean and easy to look at, and basically sums them up in different stages. Stage 1 being our uncomplicated, stage 2 being our complicated fibropurulent, and stage 3 being our complicated organizing. So the complications of, I don't know why I did that. The complications of empyema and parapneumonic effusions, they'll have pleural peel, which we kind of talked about. That's that with that last stage that usually requires open thoracotomy, sepsis, pleural thickening, pleural fibrosis, pleural calcification, and bronchopleural fistula formation, which usually requires open thoracotomy. You can have VTE and empyema necessitans. Anybody know what that is? Yeah, yeah. It can out of the pleural space and into the neighboring chest wall or surrounding soft tissue. I didn't know what that was. So factors associated with poor prognosis in patients with parapneumonic effusions. If the pleural fluid is pus, the pleural fluid bacterial smears are positive. The pleural fluid glucose is less than 60. Pleural fluid bacterial cultures are positive. Pleural fluid pH is less than 7.2. The LDH is more than 3 times the upper limit of normal, and the pleural fluid is loculated. The long-term survival of patients with parapneumonic effusions is good. It's provided therapy is adequate and prompt. In patients with pneumonia, the presence of parapneumonic effusions is associated with an increased likelihood of being admitted and results in longer hospital stay and increased mortality. Again, mortality is high in patients with empyema. So it's good to have them on the right therapy early on and have the right people involved early on. There's the rapid scoring system, which was Raman and colleagues have developed to kind of give a prognosis or who are at risk for poor outcomes at the time of their presentations. The scores range from 0 to 7, with values between 0 and 2 assigned for renal function and age, with higher scores given for worse renal function or older age, and scores of 0 or 1 assigned for purulence of the effusion. A non-purulent effusion receives a score of 1 where the infection was hospital acquired or not, and then dietary factors. In one study, patients in the high risk category, those with a rapid score of 5 to 7, were found to have at least a 30% chance of dying in the subsequent 12 weeks. And thus similar patients may warrant more invasive initial therapy. Take-home points. Patients with pneumonia and an effusion of more than minimal size should have a therapeutic thoracentesis. If the fluid cannot be removed with a therapeutic thoracentesis, a chest tube should be inserted and consideration be given to the intrapleural installation of fibrinolytics. If the loculated effusion persists, the patient should be subjected to video-assisted VAT surgery, and if the lung cannot be expanded with this procedure, a full thoracotomy with decortication should be performed. I think some of the new studies, they're an attempt at creating guidelines, the CHEST 2000 guidelines, and then you have the British Thoracic Society guidelines of 2010. They pretty much all say the same thing, but where I think it's important is getting surgery involved early and to work closely with them. Dr. Debian made this a great point that getting them involved early is paramount in the treatment of these patients, just because the mortality associated with empyema is so high and treatment failure does happen. So I want to thank Dr. Debian for his help, and if anybody has any questions, please feel free to ask.
I have a quick question.
Sure.
I've heard, I don't know how true or how much this affects, but lidocaine infusion, like when you're numbing up and how that affects like the pH in your pleural fluid analysis. True or false?
Yeah, we actually just talked about this. That's funny you say that. Bianca, the IP fellow, and I were talking about this the other day, and I think it falsely lowers your pH with the lidocaine. And I don't know the direct studies of that, but we talked about it the other day, and I think we asked Dr. Cohen. He said, yeah, it can lower your pH.
But it doesn't affect anything else. It's just the pH that's affected.
Just the pH, yeah. And something that is important is when you are getting your thoracentesis that you have to do the pH in an ABG machine, or else it's not going to be correct. Dr. Kelly.
Yeah, I'm just gonna piggyback on that comment. Some hospitals use pH paper, which is notoriously not trustworthy. Also probably just like your questions for pH. You'll clog the gas. So bigger hospitals have dedicated analyzers for pleural fluid, which is but know what you're doing with your hospital with pH paper. In that case, it kind of runs into saying that, you know, do I trust more the pH or the glucose? Like you said, the pH is certainly more sensitive to glucose. And then I like the point that you made with the presentation with sepsis, and specifically you didn't say septic shock. So we don't see septic shock in the unit often with people with empyema. I think they're much more likely to language with sepsis and not overt shock. In that case, these people are kind of easy to miss once they've been sitting there for a few weeks, and you're kind of scratching your head about why they're kind of febrile and IV is unaffected use case for DVTs or whatever. But it's something that we'll miss to maintain a low, a high index of suspicion for it, because it's such mortality associated with not doing it. Great talk.
Thanks.
So when you